Now coming to the next question, a patient is planned for dental procedure. In which of the following infective endocarditis prophylaxis is not indicated? Now these days, infective endocarditis prophylaxis is not indicated in most of the congenital heart diseases which are acyanotic types and which have not been touched or which have not been repaired. Okay, so with the help of that, you can easily conclude that the patient with ASD will not need infective endocarditis prophylaxis in case of dental procedure. This chart is very helpful. A lot of other questions, related questions, could be asked from this chart. So you should remember when should we advise or when should we give prophylaxis in case of dental procedures to prevent the patient from developing infective endocarditis. Now, obviously, if the patient is having a prosthetic cardiac valve, or prosthetic material is used for cardiac valve, if he had a history of previous infective endocarditis, then we will have to give him the prophylaxis. Obviously, in case of cardiac transplantation, also you will need to give infective endocarditis prophylaxis, especially when they develop cardiac valvulopathy. Now, coming to the CHDs. In CHDs, you can see unrepaired cyanotic CHD, including if the shunt has already been done. In those patients also we need to give prophylaxis. Completely repaired CHD with prosthetic material or device, but only during the first 6 months after the procedure you will have to give the prophylaxis. Repaired CHD with residual defect at the site or adjacent to the site of a prosthetic patch, so which will inhibit endothelialization, then also we will have to give the prophylaxis. So in case of unrepaired cyanotic CHDs, you will have to give prophylaxis in every case. Now coming to the next question, a patient with swelling in front of the neck came to the clinic, he complained of fatigue. On examination, hypothyroidism was found, along with it anemia was present, which is more common in this case of patient. So hypothyroidism, the type of anemia which is associated with hypothyroidism, is a macrocytic anemia. So the answer is macrocytic anemia. Here you can find the reference. It is from Nelson's textbook. Yeah, in hypothyroidism, the type of anemia is which is present is macrocytic anemia. I have summarized other features of hypothyroidism here in one slide. You can see this. Here the hematological complications are mild anemia. Patient can also develop acquired von Willebrand disease rarely. Hypothyroidism patients can also develop von Willebrand disease. Apart from that, decreased C and S protein level can also be seen in these patients. So our answer is very clear, which is macrocytic anemia. Now coming to the next question, a clinical finding in this obese patient with BMI more than 30 is shown here. Which of the following is most likely to be associated with this? So the patient is having acanthosis nigricans. This is called as acanthosis nigricans. And acanthosis nigricans is associated with insulin resistance. So insulin resistance with obesity, along with the hypercholesterolemia and hypertriglycerides level, these apart from that, presence of hypertension, these all things are called as metabolic syndrome, or which is also called as syndrome X. So the answer is metabolic syndrome. Acanthosis nigricans, you can also remember, can also be related to internal malignancies, especially the GI malignancies. This can also be a feature of GI malignancies. Now here you can see the reference, obesity and insulin resistance. It is usually associated with obesity and insulin resistance, which is a feature of metabolic syndrome. A patient with ALL shows lymphoblast developing. He develops pain, abdomen and decreased urine output. Workup shows increased potassium, increased uric acid level. Next step of management. So the patient has developed basically tumor lysis syndrome. In tumor lysis syndrome, what happens? A lot of tumor burden gets lysed at the same time, resulting into a lot of things from inside the cells coming out. So in this case, in these types of patients, the first thing we have to do is to hydrate the patient. So the first urgent thing that you will be required to do will be hydration. Now in tumor lysis syndrome, what happens? What are the things which increase from when the cells break? uric acid, phosphate level increase, and if the phosphate would increase, then calcium would decrease. Okay. Apart from that, the potassium is also found more in intracellular compartment, so potassium will also increase. So you should remember uric acid, phosphate and potassium, they increase and calcium levels decrease. Apart from that, it can be associated with renal dysfunction. Now it is most commonly seen in Burkitt's lymphoma and ALL. Okay, it can be seen in a lot of tumors, but these are more, you can say, notorious for developing tumor lysis syndrome. The treatment mainly involves proper hydration, and we have to give allopurinol. Now this is the drug also which can be used, rasburicase, which is an enzyme that degrades uric acid. Now coming to the next question, which is a patient with asthma developed nasal polyps and sinusitis. So this is a type of triad, it's called Samter's triad. This happens when the patient is sensitive to aspirin. So the answer is aspirin. Okay, you can see Samter triad. A nasal polyp is associated with aspirin sensitivity and asthma. Now, next question. A 4-year-old boy is brought to hospital with complaints of frequent fall when he tries to run. He is also found to have difficulty in getting up from squatting. His muscle biopsy image is shown. Okay, some image was shown. Which of the following is true about his condition? Excellent prognosis if detected early. Death usually occurs by 3rd decade. It is a post-viral pathology, mitochondrial inheritance. Now, here what you will see, the answer is very simple. The patient has developed Duchenne Muscular Dystrophy. Now in Duchenne Muscular Dystrophy, the prognosis is very poor. Okay, the patient usually dies by 3rd decade of life. So this is the answer. Now, I have also summarized Duchenne Muscular Dystrophy in one slide. Here you can see this is usually most commonly X-linked recessive kind of disorder, and the clinical features involve proximal muscle weakness. Patient might develop signs which is called a Gower sign, in which patient takes a lot of help while standing up. You can see I have a video of this. I'll keep a link of it. The Gower sign is very much you can say directing. It will help you a lot in diagnosing Duchenne Muscular Dystrophy. Apart from that, hypertrophy of calf muscles are seen. The second muscle to get hypertrophied is the tongue muscle. Then it is also associated with intellectual impairment, cardiomyopathy. Here the mortality occurs by 2nd or 3rd decade of life. How can you diagnose it? You can do a serum creatine kinase level, which will be very, very high. You can do a genetic evaluation of dystrophin gene, and the diagnostic tests that usually might be required in some cases when these earlier dystrophin gene is negative, then we can go for a diagnostic test, which is muscle biopsy with immunohistochemistry. The treatment there is no curative treatment of this disease. Glucocorticoids are usually given, which decrease the speed with which the strength of the muscles are declining. So the glucocorticoids are used. Now coming to the next patient, a patient presented with emergency with features of jaundice. On investigation, he had raised bilirubin, increased SGOT, SGPT and ALP. What is the diagnosis? So if this was the question, then the answer to this is hepatitis. You can remember this chart, which will help you to understand which kind of disorder can be seen in what kind of liver pattern, liver tests. Here you can see that if the patient in hemolytic patient in hemolysis, bilirubin is high, but it is indirect bilirubin which is high. The other things are normal because the liver is not involved actually. In case of acute hepatitis, bilirubin is high. Both types of bilirubin, direct and indirect, can be high. And the most important thing is that the OTPT are very much elevated. Okay, aminotransferases are very much elevated. Alkaline phosphatase can be increased, but it is less than 3 times the normal elevation. Okay, now coming to the chronic disorders and chronic hepatitis, you have to remember that again here the bilirubin, both of the bilirubin fractions can be high. OTPT would be increased, but not very much increased as in case of acute case, and the alkaline phosphatase is also normal to less than 3 times the elevation only. Now in case of obstructive jaundice, here both fractions may be elevated, Here, the most important pathognomic thing is that the alkaline phosphatase is elevated, very much elevated, and can be more than 4 times the normal. So this is the thing which can help you identify what type of jaundice the patient is having. Now, coming to the next question. 11-month baby is brought to the emergency with pain abdomen and multiple episodes of vomiting. On examination, mass was palpable in right lumbar region where enema image was given. So what is the patient having? Now, based upon only the first 2 lines, you can pinpoint that the patient had developed the features of intussusception. They have also given the barium enema image where the claw sign could be seen. Okay. Now, this is the triad of pain with palpable sausage-shaped mass in abdominal cavity, along with which if the patient is having bloody or current jelly type of stool, then the patient is having intussusception. This classical triad is not seen in a lot of patients, but this is considered to be a triad. Pain abdomen with abdominal mass, along with which the patient is having a bloody or current jelly type of stool. Now, next question is, 6-year-old child presented with recurrent UTI. Micturating cystourethrogram image is given below. What is the most likely diagnosis? So the patient, the dye, when in micturating cystourethrogram, what we give dye to the patient from the urethra. Now this dye should have, in a normal case, the dye would only remain in the bladder. Here what you have seen, the dye has entered into the ureters. So the patient is having vesico-ureteric reflux. Few more things that you should remember in case of a recurrent UTI, or if the child is presenting to you with UTI, there are some investigations which are recommended. In a child less than 1 year, we have to do a renal and bladder ultrasound. USG is advised, along with its DMSA and MCU. They should be done in a child of less than 1 year who is having UTI. This recommendation is by Indian Academy of Pediatrics, and it is a very practical thing that we should do in patient coming with UTI. We should stratify according to the age and advise these investigations. Now, in the age, if the patient's age is 1 to 5 years, then apart from USG, we should also do DMSA scan after 6 months. And if it is abnormal, then you have to do MCO. In more than 5 years child, we have to do USG always, and then we can do DMSA and MCO only if USG is abnormal. Okay. So more investigations are done in lesser age child, and as the child age grows up, less invasive tests are done. Now, one more thing that is asked from this recurrent UTI thing is antibiotic prophylaxis. When is antibiotic prophylaxis given? In case of a vesico-ureteric reflux of all grades in infants less than 2 years, it should be given. This is the recommendation by the Urological Society, and this is the recommendation by the Indian Academy of Pediatrics. You can remember these because antibiotic prophylaxis can also be, this is an important thing that could be asked from this topic. Now, it is recommended with UTI below 1 year in almost all patients while waiting for the imaging reports. If the vesico-ureteric reflux is present of all grades in infants less than 2 years, and 3 to 5 in 2 to 5 years. Recurrent febrile UTI, if the patient is having 3 or more episodes in a year, then we have to give an antibiotic prophylaxis. According to the IOP also, grade 1 or grade 2, they have written vesico-ureteric reflux, presence grade 1 and grade 2 for 1 year, and grade 3 or more for 5 years. Now coming to the next question. Identify the following condition: bladder exostrophy, gastroschisis, omphalocele, and malrotation. Now you can see this lesion is present in the lower abdomen below the umbilicus. The lesion that he is having is bladder exostrophy. Another very common confusing question that they ask is, what is gastroschisis and omphalocele? I have summarized the difference between them over here. Now, this lesion is gastroschisis and this lesion is omphalocele. You can see the umbilical cord is not involved in gastroschisis, and in case of omphalocele, the umbilical cord is included in the lesion. This is very important. By the picture only, you can easily identify which is gastroschisis and which is omphalocele. Here, the second thing that you should see is that there is a membrane present over here, while there is no membrane. There is no membrane over here, while there is a membrane present over here. Okay. Now, if further questions that could be asked could be the involvement of liver. Here, the liver is usually not involved. Here it is common for the liver to be involved in this lesion. Okay, so this is omphalocele and this is gastroschisis. Coming to the next question, a child presented with increased TSH but thyroid hormone level is normal. What test is best done to assess the functional status in this child? So for assessing the functional status of the thyroid gland, you can do a radioactive iodine test or a technetium-99 scan. So since that is not given, so we will go by technetium-99 scan. You can find the reference over here. The diagnosis is confirmed by low uptake of radioiodine or technetium-99 per technete scan. So this is a very important test which can be done to assess the functional status of thyroid gland. Now coming to the next question, 11-month-old child had recurrent jerky movements of limbs. He developed regression of milestones. EEG shows hips rhythmia. What is the anti-epileptic drug of choice? In this, what the patient is having is West syndrome. Okay, and in West syndrome, the drug that we give is ACTH. If the ACTH can't be afforded, then we go for steroids. So West syndrome, I have summarized it here in one slide. It usually starts in infancy. The triad of West syndrome is infantile spasm, developmental regression, and hips rhythmia in EEG, which was in our case. Now, the treatment is ACTH injections or oral steroids. The second line treatment which is used in tuberous sclerosis is vigabatrin. Now, the drugs, if they won't give these options, then you will have to go by vigabatrin. Now, Lennox-Gastaut syndrome. This is also one syndrome that you should remember, and it is a related thing that can be asked. In Lennox-Gastaut syndrome, the age group that is affected is 2 to 10 years, and it has a triad of developmental delay, multiple seizures, plus EEG shows 1 to 2 Hz spike and slow waves with polyspike burst in sleep. Here the treatment that is given is clobazam, valproate and lamotrigine when the patient is having drop attacks. Now coming to the next question, a child was brought by his mother with episodes of loose stools, complained of drowsiness, lethargy, skin pinch, was going back very slowly. Child did not accept breastfeeds. What is the class of dehydration? So the patient is also having drowsiness, along with which the skin pinch is going back very slowly. So the child is having severe dehydration. We should remember the WHO classification of dehydration. They have divided into no dehydration, some dehydration and severe dehydration. In severe dehydration, as in case of our child, the child would become lethargic and sensorium would be affected, along with which the skin pinch would go back very slowly, which is not the case in some dehydration. Skin pinch goes back slowly here, and the patient might be irritable and restless, but he is not drowsy or unconscious. Now coming to the next question, mother was worried that the baby did not pass urine on postnatal day 1. What advice will you give? So in this case, we should always remember that the normal baby passes urine usually by 48 hours of life, and he usually passes stool by day 1 of life or 24 hours of life. So in this case, which is a normal thing and a very common presentation, many times babies are brought to the OPDs with this complaint. So here you just have to counsel the parents and continue breastfeeding and observe. A child is brought to emergency with sudden onset breathlessness. Chest X-ray was given. What is the correct option regarding this? So here, the patient having a child with sudden onset breathlessness, we always have to suspect in less than 5-year child presence of foreign body. So they have already given the options for foreign body. Best method of removing foreign body is usually fiber optic bronchoscope, which is wrong. No, we don't use fiber optic, we use rigid bronchoscope. If complete lung obstruction leads to filling of lung due to ball valve mechanism, if there is ball valve mechanism, then there would be emphysema on that side. Okay, look, so which is seen not in complete lung obstruction. Localized area of decreased breath sound is suggestive of foreign body obstruction. Yes, that is correct. Not correct. Now look at this foreign body aspiration. Here I have summarized it in one slide. The history is most important, which can help you to diagnose foreign body aspiration. The history that usually we get is the ingestion of the child was eating nuts or seeds and suddenly he started choking and getting breathless. On examination, you can find asymmetrical breath sounds or new onset wheeze is also very highly suggestive of foreign body aspiration. Chest X-ray, you can see air trapping might be there. They can be asymmetrical hyperinflation or which is called as obstructive emphysema. Later on, the patient might develop consolidation. Treatment is with rigid instruments, rigid endoscopy or rigid bronchoscopy. Now, look at this. Next question. Identify the at-risk infants among the following. Infant with a single mother, birth weight of 2.5 kg on artificial feed, or birth order of 3 or more. Now, one thing that you should remember is that there is no standard definition of at-risk infants. Okay, this picture I have taken from AIMS protocol. Here you can see that it's clear there is no standardized criteria for defining high-risk infants, even in tertiary care settings. But the children, according to the situation, they can be considered to be high risk. So birth weight less than 1.5 kg, gestation less than 32 weeks, or infants with birth weight of more than 1.5 kg or gestation 32 weeks can also be considered to be high risk if they are IUGR, if the intrauterine growth centile was less than 3rd centile, if not 10th, okay, 3rd is here, then, or if they had meningitis, they received mechanical ventilation, HIE, if they had any major malformations, inborn error of metabolism, if they had symptomatic hypoglycemia, symptomatic polycythemia, retrovirus, the mother was retroviral positive, or if there was any hyperbilirubinemia requiring exchange transfusion. So if patient was having a long NICU course, then that baby would be considered to be having, considered as a high-risk infant. Abnormal neurological examination and discharge, major morbidities such as chronic lung disease, IVH grade 3 or more. Okay, so if the baby in NICU had a very bad course of hospital stay, a serious course, then that baby would be considered as a high-risk infant. Now, none of these options were given in our question. So, as I believe this question had more than one options which were correct. Okay, so the answer here you can pin it down like this. Infant with a single mother. Well, infant with a single mother, birth weight of 2.5 kg. This is certainly not. Birth order of 3 or more. This is also certainly not. Since you can rule out these two, you can see that the infant on artificial feed, yes, these patients could be considered to be at high risk infants because they are prone to develop malnutrition, they are prone to develop recurrent infections. Mostly these babies are also bottle fed, so these definitely could be considered a high risk infant. An infant with single mother, if there are multiple options which you had to choose, then you can also go for this infant with single mother. So this can also be considered to be at risk infant because the caregiver might not be able to give care to the baby as is required. So with this, we come to the end of today's session. Thank you.